actually have catastrophic outcomes. This is a very common, comes in the news also. If we see the etiology, still the most common syncopes are neurally mediated and orthostatic syncopes. The cardiac syncopes are probably the second common, most common cause, with arrhythmic causes of cardiac syncopes are more common compared to the structural causes. The non-cardiovascular things are, including the neurological syncopes, are probably around 10 to 12%. Even in the old cohorts where we know that these things have been published quite some time back, the most common syncopes are still the vasovagal and the orthostatic. The cardiac syncopes combine to around 10 to 12%, and seizures and other neurological syncopes are probably less than 10%. So when we see a syncope, the most important thing is to see whether it is a benign or a not so benign cause of a syncope. To classify the patient as a high risk or a low risk, we have to differentiate whether it is a cardiac versus a non-cardiac syncope. And when we know it is a cardiac syncope, we should distinguish between an arrhythmic and a non-arrhythmic cause of syncope. There are several conditions which can mimic syncopes, like starting from seizures, partial seizures, cataplexy. Cataplexy is a very common thing. And a word about seizures, including absence seizures. Some vertebrobasilar TIAs can present with loss of consciousness, and some metabolic syndromes, metabolic disorders, and obviously the subclavian steal syndrome, which we see in our practice also. So if we see the syncope mimics, you can conveniently differentiate between those disorders which can cause loss of consciousness and those which do not cause loss of consciousness. It is those disorders which can cause loss of consciousness, like epilepsy, metabolic disorders, and posterior transient ischemic attacks, that can cause a significant diagnostic dilemma with our syncope. So when we approach a patient to syncope, mind you, it is the history that gives us the maximum information. Whenever we have an episode, each episode of syncope must dig deep into the history and presentation of the patient. We must have the details of the comorbidities and the past history of the patient. Family history is very important. A basic ECG gives good information in most of the patients. And of course, following that, we can do the echocardiogram. We have several rhythm monitoring devices. Cardiac imaging is coming up in a big way, just as Ramesh sir is talking about CT coronary angiogram. Cardiac MRI is very essential in management of these patients. Genetic testing, and of course, now the role of electrophysiology studies, diagnostic studies, is much less compared to previous things. So a word about, just to see how we can differentiate these things. Younger patients usually have vasovagal syncopes, and they have genetic syndromes like the long QT syndrome or Brugada syndrome, or genetic cardiomyopathies like RV dysplasia and hypertrophic cardiomyopathy. Whereas the elderly patients who have more of a cardiac problems, structural heart disease, valvular heart disease, ischemic cardiac disease with left ventricular dysfunction, and some neurally mediated diseases can be seen in the older patients. A word about exercise-induced syncope. This is a very important thing that we must understand. Exercise-induced syncope is usually cardiac until proved otherwise. So majority of these cardiac diseases can cause exercise-induced syncope, like outflow tract obstructions, pulmonary hypertension, cardiomyopathy. Some of these cardiomyopathies, a very common and undiagnosed thing is anomalous origin of the coronary arteries. Several of the arrhythmic syndromes, like the long QT syndrome, can cause syncope. Mind you, the syncope can occur immediately after exercise. Once the exercise is terminated, we can have a syncopal episode in these patients. We usually do some treadmill in these patients, and we monitor these patients for at least 10 to 15 minutes after the treadmill is completed. So when we see a patient with syncope, if we have to differentiate between the cardiac and neurological or other causes of syncope, the most important thing is the clinical history. See the mode of onset, duration, what are the factors that are precipitating, and how was the consciousness regained, and other associated factors and predisposing factors. So a rapid sudden onset is usually cardiac. If it is unrelated to posture, it is usually arrhythmogenic and sometimes seizure disorder. And if it is associated with a postural change, usually it is orthostatic hypotension. Cardiac episodes are usually very short, usually less than 1 minute, hardly more than 5 minutes. Seizures are usually longer, and the patient regains consciousness very fast if it is a cardiac syncope. when compared to neurological cause. Usually they have some post-ictal episodes. See the triggers. As we have discussed, exercise is a very important trigger for cardiac causes. If a patient has syncope on arm exercise, suspect subclavian steal syndrome, and several other things like head rotation, pain, grief, and other things like vasovagal syncope and situational syncopes with micturition, defecation, and other things. See what is associated. Aura is associated with seizure disorders, especially complex partial disorders. Several prodromes can be seen with vasovagal syncope. With CVAs, in the posterior CVAs, we can have symptoms like vertigo, diplopia, and post-ictal confusion state is more associated with a neurological thing. Family history is very important, especially when you are considering genetic cardiomyopathies and channelopathies. So this thing has been described several times. It has discussed. Syncope versus seizure is a very common thing, but if you actually dig deep into the history and see the presentation, see what are the associating and frustrating factors, it's not going to be very difficult to distinguish between a seizure and a syncope. We know that prodromes and tongue bites and myoclonus can distinguish syncope with a seizure. What we usually used to think that incontinence is very uncommon in syncope, but it is not so. Incontinence is not uncommon with syncope. Some myoclonus is not uncommon with syncope, and other things like fatigue and all can be there, especially in younger patients. So these symptoms like incontinence and fatigue, they are of limited value in distinguishing between a syncope and a seizure. So there is a list of these things that can give you how to diagnose. What are the things, if you see in the history, the reflex syncope, cardiac syncope, especially if you see some ECG changes like a bifacicular block, if you have some AV blocks, like if you have some sinus bradycardias, non-sustained VTs, probably these are all things that can give you a hint about how to distinguish between these two things. So quickly we'll see a few case scenarios where we will have some difficulty. But before that, so once we know that it is a cardiac cause and not other non-cardiac causes, we have to distinguish between arrhythmic and non-arrhythmic causes. As sir has rightly pointed out, there are acute MI can present in many different ways. One of the different ways is we have seen patients presenting with syncope, especially with infraval MIs, valvular heart disease, even acute pulmonary embolism. We have seen patients presenting with syncope. A clinical background, a good ECG and echo will usually give you the diagnosis in these things. And mind you, unexplained syncopes are usually arrhythmic. Again, missed beats is a common clinical term. If a patient comes to you with missed beats and a syncope, the arrhythmias can range from occasional ectopics to sustained arrhythmias. Always look for structural heart disease. Always think of myocarditis, drug-induced and other hormonal imbalances. Missed beats patients presenting with syncope are usually arrhythmic disorders. And when you have such a patient, quantify the rhythm disturbances by doing a Holter monitoring for 24 hours or 48 hours. Correlate the symptoms with the findings, and imaging is very useful in some of these patients. When you have to worry about these missed beats, when the patients have structural heart disease, when these missed beats are high frequency in a 24-hour Holter monitoring, when patients have syncope or pre-syncope. So mind you, both atrial and ventricular arrhythmias can present with syncope and other things. Quickly, let's see some case scenarios. If you have an ECG like this, which is a complete heart block, or an ECG like this, which is a 2:1 AV block, or an ECG like this, I think the diagnosis is pretty straightforward. If you have an ECG like this, which is pretty ominous, the diagnosis is pretty straightforward. What happens is, in our routine clinical practice, we see several patients with some atypical presentations, like this patient who came to us with palpitations. He was a 35-year-old male. So he has atrial fibrillation. This is a very difficult problem, a young male presenting with atrial fibrillation. Now, of course, we have to see other things like hypertension, thyroid, and structural heart disease. We have to see the patient has other associated conditions like myocarditis. A lot of these patients have sick sinus syndrome, and now we are seeing several genetic conditions presenting with atrial fibrillation in the younger patients. We have actually seen a patient with a desmoplakin, which is known for arrhythmogenic right ventricular cardiomyopathy, presenting with atrial fibrillation in a young patient. Another patient coming to you with palpitations and pre-syncope. This, of course, is a flutter. most of these patients have a structural heart disease, but keep in mind that most of these patients do have missed beats in the form of common, very constant and very prominent atrial ectopics. If you do a Holter, you will have some pauses. If you do a Holter, you will see some pauses in these patients. It is actually those pauses after the flutter terminates that is causing the syncope, not the flutter per se. And ablation is very effective in these patients. This, of course, rings our bell, rings the alarm bells actually. This is a very common presentation. We know that patients who have a previous CAD can come to you in an unresponsive state. If you do Holters for these patients, you will pick up a lot of ventricular ectopics, atypical, very high burden, non-sustained VTs and all you can have. So these patients do have a risk of sudden cardiac death. You have to stabilize these patients, see if the LV function is poor. You have to go for an ICD or a CRTD depending on the LV function. Imaging is especially useful in these particular patients. Of course, there is a role of ablation coming up recently if the patient has a VT storm. A lot of patients, young patients, come to us with syncope or palpitations. This is a common pattern. Now, this is one of the patients who came to us. He was being managed as a seizure disorder. So when we took the ECG, we saw that this is a typical Brugada pattern. And when we dig down deep into the history, it was more suggestive of syncopal episodes than a seizure episode. So this is a typical Brugada pattern. When you see this kind of an ECG, you have to see the family history. You have to see the genetic screening is very essential. If it correlates well, if the symptoms are correlating with the findings, he qualifies for a ICD. This is a very common thing. A young male coming to you with a sudden collapse history. Genetic cardiomyopathies are increasingly being recognized now. This patient is, of course, having a hypertrophic cardiomyopathy. If you do a Holter for these patients, they are likely to have a lot of ventricular ectopics. Many of these patients do have atrial arrhythmias also. AF, in fact, the most common arrhythmia in hypertrophic cardiomyopathy is atrial fibrillation. So when you see such patients, you have to dig deep into the family history, do a genetic testing. Imaging is mandatory now in most of these patients. And of course, we have several treatment modalities, including the newer drug mavacamten. This is a very common clinical scenario, a young patient coming with palpitations and syncope. If you see, there is a pre-excitation in these leads. And when we see a pre-excitation with a syncope, this is a high-risk WPW. We should avoid giving beta blockers or calcium channel blockers, and ablation is potentially curative in these patients. This is an interesting case, exertional syncope, as we have discussed a little while. This young girl had an exertional syncope after termination of her exercise. So this is a typical long QT1 type 1 phenotype. Genetic testing is most valuable in these patients. We have to identify the subtypes. The treatment actually depends on the subtype of the long QT syndrome. We have several options, including medications. We can use pacemaker in some of these patients, and ICD is limited to some patients. We can have acquired causes of long QT syndrome also. The other spectrum, we can have a short QT syndrome also. These patients also present with malignant arrhythmias and syncopes. And here, mind you, short QT syndromes are also associated with atrial arrhythmias. Now we know that many of these genetic disorders, including genetic cardiomyopathies, can actually have atrial arrhythmias also, not just the ventricular arrhythmias. Again, this is a very important thing. If you see the ECG, ECG is classical of a small epsilon wave. These patients do present with syncope very early in their age. Previously, we used to call ARVC. Now it is just arrhythmogenic cardiomyopathy. Cardiac MRI is very informative in these patients, and genotyping gives us a lot of information managing these patients. And finally, we have an elderly male who has a history of ischemic heart disease, now presents with syncope. We don't know. The ECG shows just some right bundle branch block pattern with left axis deviation. We are not sure. It's a trifascicular block. We are not sure what is the cause, whether it is a bradyarrhythmia or a tachyarrhythmia. So the thing is, you assess LV function, do an imaging if needed, do a Holter monitoring. Very rarely you may have to do an EP study in these patients, and then you decide about a pacemaker or an ICD in such group of patients. So these are the various clinical scenarios as far as cardiac arrhythmic syndromes, arrhythmic syncopes are concerned. So a word about the rhythm monitors. We have several rhythm monitors that are available. Now we have loop recorders, external loop recorders, which can be done up to 30 days. And probably the most underutilized diagnostic modality is the implantable loop recorders, which can be used for more than 1 year. Some of them can be used up to 3 months. So these loop recorders are very useful in those patients who have very, the frequency of syncopes or episodes is very low, maybe once in 6 months and once in 1 year. We don't know what is the cause of syncope. ILRs are very much useful in diagnosing the cause of syncope in these patients. The role of EP studies has reduced much. When I was a student, we were doing a lot of diagnostic EP studies just to do the sinus node studies, for AV conduction studies, for inducible VTs. We used to do a lot of VT inductions. But now with imaging, especially cardiac MRI, has changed a lot of our understanding, especially in patients with cardiomyopathies. EP studies, diagnostic EP studies, the role has been reduced. Now we use only in patients who have unexplained syncope, and we don't do EP studies routinely in our patients. So we know that once we have a diagnosis of these patients, we have to tailor our treatment specifically. Again, see, if you see the recommendations, the pacemakers are there in symptomatic patients, but again, the ILRs are actually a class 1 or class 2 recommendations in patients where we have not documented the bradyarrhythmia. Even in tachyarrhythmia patients, this is a very important subset, patients who have a bundle branch block with unexplained syncope. If the EF is less than 35, obviously they qualify for an ICD, but EF is more than 35. This is a very common clinical problem. What to do with this patient, EF 30, more than 35 unexplained syncope? It is here that the role of ILR and the diagnostic EP studies comes. So probably I would think ILR is more important than a diagnostic EP study in these patients. But if you have something positive, definitely he will go for a device therapy. For tachyarrhythmias, again, catheter ablation is more useful in SVTs. For VTs, if it is a structural heart disease, it is ICD, that is a first line therapy. And if it is structurally normal heart, we should go for a catheter ablation. So finally, syncope has a long list of differential diagnoses, long enough to confuse most of us. We have to differentiate between reflex syncope, cardiac and neurological cause. It is fairly easy once we see the clinical presentation of the patient. Once we know it is a cardiac cause, we have to dig deep whether it is an arrhythmic cause or a non-arrhythmic cause. A meticulous history and timely ECG are paramount for diagnosis. Echoes are there, Holters are there. Don't forget the loop recorders, implantable loop recorders. Imaging has an increasing role, especially in cardiomyopathies and myocarditis. And not even that, not only that, just as we have seen in patients with coronary artery disease also, to document viability, to document the scar, cardiac MRI has an increasing role. And now EP studies have a limited role. Thank you.
Thank you, Dr. Ramakrishnan Garu.
Thank you.
So one small question. The implantable loop recorders, you said they're very rarely deployed and underutilized. In the global, in the last, let us say, decade, what are the causes which are identified by the implantable? In other words, what are the rare causes of syncope?
Sir, ILRs are actually, in the sense that when patients have very few episodes, like one syncope in 6 months, one syncope in 1 year, the frequency is very less. So those patients we advise ILR. And whatever few ILRs that I have done, most of the times it was a non-cardiac syncope. So we have diagnosed that it is actually not a cardiac thing. We were thinking of whether it is bradyarrhythmia, or sometimes we have effectively ruled out a cardiac cause of a syncope in these patients. So we thought that it is something else.
Globally, how many loop recorders have been implanted, implantable loop recorders, and what is the statistics they must have had?
Yeah. So I don't have the exact numbers, sir, but in the US, actually ILRs are fairly common. In patients who present with syncope, at least around 3 to 5% of the patients who present with unexplained syncope, mind you, these are patients with unexplained syncope who have already had a good thorough investigations, and patients who are left with unexplained syncope, many of them actually go for our ILRs. But in India, the role of ILR, the utilization of ILR is very much less because of the cost factors and the yield. We are not sure about the yield of the ILRs.
So even after ILRs, there will be unexplained syncopes?
No, sir. In the sense we can effectively rule out a cardiac cause of a syncope, especially an arrhythmic cause of a syncope. Still, almost 30% of these patients have unexplained cause of syncope. Most of them are vagal syncopes.
Yeah, in neurology also, yeah, ILRs are coming into play. And especially when we give a diagnosis of endoscopy, this thing, embolic stroke of unknown source, where we have to, this ILR oblique long loop recording has become a mandatory requirement before we make a diagnosis of embolic stroke of unknown source. ESOS is in what short form it is called as. Most of us tend to say, and general guideline is as